Hello, my name is Dr. Simon Hammond. I'm the Programme Manager and Research Fellow for the Perfected Research Programme. Unfortunately, I cannot be with you today. I'm currently in Liverpool, which is a lovely part of the world, I'm sure we'll all agree, but I would much rather be in Yorkshire. Um, so, what I aim to do the next 15 minutes is give you an insight into the Perfected Research Programme, but particularly focus on the trial which we are currently running with colleagues from Prindisfield, which is hopefully where you're all based today. So what I'd like to do first of all is start by giving you guys an overview of what I intend to talk about for the next 15 minutes. So what I want to do, as I mentioned, is provide a bit of a context and background to the trial, talk about the phases of the research programme, talk briefly about kind of how the intervention was created and a little bit about it, focus on the key features of the trial, and then talk about what next from the Perfected Research Programme. Unfortunately, this presentation won't be as interactive as I'd like it to be, but hopefully the next 14 minutes or so should be worthwhile. So why Perfected? Why hip fracture? Why people live in dementia? And why now? And why acute settings? So I think we'll all agree and testify, and I think also I'm very aware that people in the room will have much more of a frontline perspective on this than I will, but the NHS provides care to an increasingly complex and elderly kind of population of patients. As we'll all be aware from media reports, people are living longer, and in many ways that presents what some have called a grey tsunami, if you like, an increasingly high level of more elderly and more frail patient groups that we as the NHS need to respond to and provide care for. Within that patient group, a significant proportion, depending on what journal article you read or what newspaper you sign up to, will also be living with dementia. Now, this particular group is obviously massive interest to ourselves, and particularly this finding from Liz Sampson at UCL, which highlighted that those people living with dementia who are admitted to hospitals have half the survival time of those sort of matched cohorts who aren't living with dementia. And what that begins to sort of demonstrate to us that perhaps the NHS settings in which we've provided care aren't as optimised as they could be for an elderly population with some sort of cognitive impairment. And one of the things that I'm frequently asked, as I mentioned, is why hip fracture and why dementia? What's the relationship between the two? So I think before we get onto that, I think it's just to say that actually fragility, particularly falls, and within that hip fractures or neck or femur fractures, are a very common orthopaedic injury, and across the globe there are millions of hip fractures annually. Now, because it's a major orthopaedic injury, and because dementia is such a growing social issue, what's perhaps not as obvious as it could be is that when older people fall, sometimes it's as a result of an undiagnosed memory or thinking problem. So in many ways, particularly for the people we're focusing on in Perfected, it can be the start on some occasions, their kind of dementia diagnosis journey. So sometimes it's a carer or a relative saying, oh yeah, my mum or my dad's been feeling a bit, they've sort of been a bit disorientated recently, and then the next thing you know, this person's been on the floor overnight and they come into hospital, and actually things start to fall into place, and sort of the thinking problems and memory problems come to the fore. So that's kind of why dementia and why hip fracture. In terms of kind of providing for hip fracture patients, there's been in the last probably maybe 10 or 8 years a big move, particularly in the UK, England and Wales, particularly in Northern Ireland, to raise the standard of care delivery to hip fracture patients, because it's such a large and expensive injury. And also in Canada, the hip attack study, which has started to orientate hip fracture as an emergency, an acute emergency, as would be a heart attack, has really brought to the fore the different ways in which we provide care, kind of from an orthopaedic standpoint for the hip fracture group. And again, I think as we'll all kind of testify really that the NHS isn't particularly awash with money, and the fact that neck and femur fractures cost an estimated 2 billion annually to the NHS is another reason why I think Perfected has a very important part to play in trying to improve outcomes for patients. So when we think about kind of drilling down a little bit more to kind of providing care for this elderly patient group, what becomes apparent from anybody who's been in hospital as a patient recently, let alone somebody who's perhaps cognitively vulnerable, is that hospitals can be very confusing places, and there's research suggests that for older people in particular with an injury such as a hip fracture, they can become confused in acute settings. Now, whether that's a result of being on the floor all night and being delirious as a result of that, whether it's a hospital kind of delirium episode, or whether actually they're fairly cognitive intact, but because they're not sleeping, and because there's lots of different people passing with different uniforms, and just a whole buzz that is the acute orthopaedic ward, people can be confused within hospital. Those who had pre-existing confusion, in which I'm talking about dementia, delirium history, are increasingly likely to be confused, but also those without can become disorientated in this acute setting. So work by a colleague, Toby Smith at UEA, highlighted that pre-existing confusion can increase the likelihood of deterioration. That's in terms of outcomes, in terms of post-fracture mobility, but also admission rates and functional decline has also been highlighted by other colleagues. So in a nutshell, people who are cognitively vulnerable are more vulnerable to have worse outcomes following an acute admission, in particular one as major as hip fracture. Within that, you can obviously appreciate that somebody with problems within memory and thinking, or somebody living with dementia, or indeed kind of confusion contained within it, that really impacts on the ability to engage in the rehabilitation program, and also the whole general recovery post-operatively, which is kind of really why Perfected starts to emerge as a hopefully quite a useful intervention and program of research to address these issues. It was also become apparent, colleagues in Nottingham particularly highlighted this last bullet point, that the confused hip fracture patients are often cared for in orthopaedic environments that may lack the expertise in managing confused patients. So one of the great things which the dementia kind of movement, if I can call it that, has done is really energised people thinking about what is a dementia-friendly environment, what is a dementia-friendly hospital ward. And what's been really good is those sorts of showpiece wards, if you like, have attracted funding. Now what we're suggesting, one of the things that's come through in Perfect, is that sometimes those learning points haven't always been cascaded down to colleagues in different departments, one of which appears to be orthopaedics. Now that is kind of changing, but I think it's just something that kind of we're very conscious on Perfected. So within that, what's really become apparent is that hip fracture patients with confusion may benefit from a treatment pathways that acknowledge the differences in presentation and care needs. So, should we be treating somebody with dementia and assessing their pain in the same way as you would do somebody without a cognitive impairment? Are dementia patients able to express pain and discomfort in the same way as other patients are? Research would suggest not, and I think, again, frontline experience would also indicate the same. So within this, when the bid was being created, the Perfected Research Programme was being put together, one of the things from talking to orthopaedic colleagues was particularly apparent was the use of enhanced recovery pathways, or ERPs, in standard elective surgery. So in a nutshell, if you were scheduled for a procedure, a hip replacement procedure, and this was elective, so an optional surgery, if you like, ERPs really talk about dividing the patient journey up into 6 phases, and they optimise the patient and their progress through each stage. So, for example, thinking about the admission, making sure the person knows when they're coming into hospital, making sure they've got all the things, making sure they've been doing their exercise, or their hydration, nutrition's fine, particularly in the preoperative setting. In the operation itself, thinking about the best way to administer painkillers to, again, kind of energise, you like, the post-operative elements of the pathway. And then, again, rehabilitation and discharge, so knowing when you will be discharged and the exercise you will do when you're discharged. So in elective surgery, those sorts of things can be spoken about with the surgeon or the doctor. And in acute settings, that's not so much the case. But another key feature of the enhanced recovery pathways is the idea of that these kind of, I guess, reducing ambiguity allows us to work together more productively as multidisciplinary colleagues, from a patient perspective, knowing where you're going and knowing when you'll be doing stuff reduces the body stress response, which is great from an economics point of view. That lowers the length of stay, therefore lowering the chance of infection, improves outcomes. Also, these sort of things have been shown to increase patient and care empowerment and participation. So, again, getting them involved in this rehabilitation and discharge process, and all that ultimately results in lower resource use and therefore, hopefully, a cost saving to the NHS. So, in elective surgery, these things are really standard practice, and what became apparent from looking at the area the perfecter was trying to engage in was one of the major questions. I think the major question that emerged was, can we use an enhanced recovery pathway informed approach to care for patients who have broken their hip and are experiencing confusion? Again, that when I use confusion, that's to encompass delirium and or dementia, or indeed delirium superimposed upon dementia. So, my line manager, Professor Chris Fox, and a wide range of international and national colleagues and experts, and many, many more who aren't on this slide because the slide isn't that big, created a program of research known as Perfected to try and address these questions and try and see if we can optimise care for this patient group. Now, the 5 years on Perfected is split into 4 work packages of 4 blocks of work, each with their different aims. The first one was trying to establish what is best and current practice for this patient group. Is there gaps between best and current practice? If so, what are they and how can these be addressed? Now, this work package came to a crescendo, if you like, or a finish in July 2015, where we drew together all the learning points and the various exploratory work we did in terms of systematic reviews, telephone surveys, observations, talking to people, all groups of stakeholders, and this created the alpha version of the Perfecter intervention. We then moved to work package 2, where we got this kind of alpha version, the first version of the intervention, if you like, and this was what the great and the good saw as a gold standard. And what we were keen to do was ensure that this could be used in real world settings. So we gave this alpha version to 3 service improvement leads in 3 different hospitals of different sizes in 3 different regions, and worked with those guys for a year to turn this into something that was practical, pragmatic, and while still delivering what we thought were care interventions and innovations which would optimise care for the patient groups we were dealing with. This finished in July 2016, and we engaged with colleagues locally. Indeed, Tracy Gordon is our service improvement lead at Pindersfield, and Tracy attended an induction event at the University of St Anglia where the project's based. And essentially what they did, the service improvement leads from the previous work package passed on learning and tips to the new in service improvement leads. And this really began to start and really kind of kick forward the trial, which is work package 3. So the idea is we've standardised the intervention and the way in which it's delivered, and what we need to do now is create some evidence to see if this is actually doable in real life. That's what work package 3 is all about, trying to see if we can improve patient outcomes. And work package 4 is all about telling the world about how great we are and trying to get some more money to bid for a definitive trial. Now the last part of that sounds quite conceited, but we'll only have 400 patient groups, and 400 patients, and if we're going to meaningfully say that, hey, this is the way you should be doing things, we need more than 400 patients, therefore we need to bid for a definitive trial. So what I'm going to do now is look at the key features of the trial itself, and talk particularly about how we'll be engaging with colleagues in Pindersfield. So the trial is a cluster randomised control trial comparing wards delivering care via the intervention, the Perfecter, versus usual care, which is kind of care as it is in that setting already. There will be 10 hospitals in total across the UK, 2 per region. So each region will have a control and an active hospital. So an active hospital being the one that's using the intervention. As I mentioned, we'll get 400 patients. We're looking for people with a confirmed proximal hip fracture requiring operation, age 60 or over at the time of the operation, having a preoperative abbreviated mental test score of 8 or below, and having somebody, a carer if you like, who sees the patient face to face to give us proxy information about that patient, how they're feeling, etc. Because what we're very aware of is that getting patients who are confused to do lots and lots of questionnaires may not be the best thing to do. So the role of the carer the care is massive in dementia care in general, so also we thought it would be useful to have this person involved in the study. In terms of different measures we'll be using, I'll not bore you too much with those, but suffice to say we'll be getting data from the patients, from the carers, and also hospital service use data from the National Hip Fracture Database. So it's a really kind of thorough approach to how the care is delivered and how the patient experiences the care. Also with active arms like colleagues like the Pindesfield site, we'll be doing qualitative research with them. So we'll be looking to speak to patients and their suitable informants, their carers, about what it was like in the hospital, how they kind of received, if you like, the intervention, the care provided. And once the study's finished, we'll also be talking to NHS professionals who were involved in the delivery and the implementation of the intervention. So what next? So Perfect is due to finish recruitment in 2017, August 2017, with a 6-month follow-up. Following that, what we're trying to do is create a report which will indicate whether or not we see it as important to have a definitive trial. We'll also look at how cost-effective the intervention was, and as I mentioned, sort of look at those views from the stakeholders engaged in delivery and receipt of the intervention. As with all research study and all contract researchers like myself, there's always the next trial. So provided the above goes to plan, or even if it doesn't, there will be learning to be gained and to transfer to other settings and other trials. So as I mentioned, we'll use this to inform any definitive bid if there should be one, or indeed the finding may be that a definitive bid isn't needed because everything's fantastic, we've changed the world, or indeed perhaps we haven't. So again, that's one of the things that come from the project. We're also very conscious that the Perfecta intervention is focused in the acute setting, and when we're thinking about people with dementia and hip fracture, their ambulance journey is massive. How these people then leave the hospital is huge as well. So there's an additional study being submitted for consideration, which is focusing on the discharge and trying to ensure that discharge is done more optimally. Well, this is kind of the end of the presentation, as I'm sure Lynn's happy to hear because I've gone over the presentation slightly. So what I need to do is obviously give the obligatory thanks to our funder and leave that slide up for 10 seconds while we look at the amazing work that the National Institute for Health Research do, and there's the reference number which I've got to put up. I think more importantly for me, I won't be there I haven't been there today, as you're probably aware by listening to this. But just to say, thank you so much for listening. Apologies I couldn't be there again. What we'll leave you with is the knowledge that if you want to know more information about the trial or the research programme in general, we have a website which I've just noticed hasn't got the web address on it, which is very helpful. I'm sure Lynn will be able to help you with that, but if not, it's www.perfected.ac.uk. Give us a Google. We've got a YouTube channel. We send tweets out. Why not, go on there, look for contact us, and sign up for the newsletter as well. That's it. I just would like to again sort of apologise for not being there and thank yourselves and colleagues in the room at Pindesfield for being involved in the Perfecta study. Thank you very much.